figure out a way to force me.
Yeah.
And then we'll all be invited to the Mickelson med spa, right?
Yeah,
Oh, I love that.
Do it.
There's like a mechanical ventilator. It's supposed to help make your lungs pretty.
Extra oxygen.
You wake up pretty. Critical deconditioning.
They sedate you. They're like, just go to sleep.
Welcome to the Critical Chats podcast,
Or as I'd like to call it, Crit Chat.
where we talk about the new and exciting developments in the critical care world and get to know the providers behind the medicine.
I am Sheila Billica, PA.
And I'm Katie Shakura, PA. We're your hosts, and we're with our producer, Sneha.
I'm also a PA.
3 PAs on a pod. Today's guest is none other than Dr. Jared Mickelson, a critical care pulmonologist whose work lives at the intersection of innovation, advocacy, and life-saving medicine. As an active member of the hospital's ECMO committee, he is advocating for advanced cardiopulmonary support here at UMass, pushing beyond the status quo to expand what's possible for patients with severe respiratory failure.
He brings a meticulous, physiology-driven approach to the ICU with a strong command of mechanical ventilation, hemodynamics, and advanced rescue therapies. He's the leading effort to bring a more robust ECMO program here to the hospital. And this isn't just about new technology, it's about building the right team, protocols, education, and culture to support one of the most complex therapies in modern medicine.
So welcome, Jared.
Nicely done.
So I guess first just tell us about you. Where'd you come from? Who are you?
Okay. 2 people I've never met before. Thank you so much. I'd love to tell you about me. So I'm from Connecticut originally. I went to school in Florida, which is a school called Lake Erie. It's one of the osteopathic schools, which is not in Erie, Pennsylvania. I think they opened up one in Erie, and then the people that owned the school very quickly realized they wanted to live in Florida instead, because it got opened like only a couple years later. But yeah, so I was down there. And then 4th year of medical school, you kind of flap your wings and go see what hospitals you like. And I kind of landed here doing 2 rotations in medicine and then in the ICU. And that was kind of that for me. I'd rotated a lot of different places. And not to say UMass has some secret sauce as far as above other institutions, but for me, this was like the perfect fit. And so I haven't really even thought about looking elsewhere, which is probably not a good thing. But, I love it here.
Awesome. It sounds like you were like hard set. You came here, weren't sure if it was the right fit, and then you're like, okay, I could see myself here once you got here.
I 100% did not expect to want to be here. I went to UConn undergrad. I always figured I would go there. I played a couple of Worcester schools in like high school, and it's not like the kindest, prettiest drive through Worcester. And so I did not expect it, but the community here, the culture, both in the hospital but in general, is awesome. And I would have never known that if I didn't do the rotation, so that was kind of a gift.
And then you loved Bullcrit.
Just loved it.
What drew you to it?
So I thought I was going to want to do EM, but I think the mixed bag of high acuity bedside management right next to being able to sit in a chair for 4 hours straight, which I don't mean that sarcastically, like you can actually just focus and dig through a case and kind of chew on it in a multidisciplinary fashion with a bunch of different people is really special. And so that's the ICU aspect of it. I didn't really know much about outpatient or inpatient pulmonary management at the time. But I think in general, that balance between I can sit and really have a thoughtful conversation and think about this, you don't really get that in the ED.
You're bouncing around.
Yeah,
you're moving a million miles a minute, and they're amazing at what they do. But being able to sit down and really be thoughtful about a case, and then the next minute being able to stand up and go to a bedside and do a lot of active critical care, I think that's really special. You need to have some variety professionally, but if you can, that doesn't, I don't mean that on a certain timeline. That could be weeks, switching rotations, days, but in the ICU sometimes it's minutes, and I think that's really nice, at least for me.
Yeah. I think that's what drew, I don't know about you, Katie, but that's kind of what drew me to critical care is I was also in between like EM and critical care. And I was like, no, I want to sit down and really like dig through the case and figure out all the stuff.
Yeah.
Cool. And then you had some kids.
Had some kids.
How many you got?
I got 3. I got 3. So I've got a 5-year-old, a 4-year-old, and a 1-year-old. And the bottom 2 are halves. And they're great. They're awesome. They're like genuinely good kids. even when they're sick. So we're pretty lucky.
Awesome. Did you find it? Oh, go ahead.
I was just going to say, what do they like to do?
Yeah.
They like to wrestle, as kids tend to do. The oldest one, we just went skiing this weekend. Pretty big deal. She went from being on the carpet, a little skiing Aladdin. And then by the end of the day, she had taken the chairlifts with me, did her green circles, and then did 3 blue squares.
Oh my God.
So we're very proud
That is huge.
of Madison. She's very proud of herself as well. She was wiggling her little butt around the living room, making sure that the other 2 kids knew how great she is. But she deserved it.
And then I'm sure you did like hot cocoa after.
Yeah, she's sneaky. So she keeps saying she wants hot chocolate, but she actually just wants the marshmallows.
So she eats the marshmallows
Right.
from the hot
Yeah.
chocolate?
So she's like, I want a hot chocolate. She loads up the marshmallows, and then she just immediately sits down, takes the marshmallows out, and gives me the hot chocolate, which is fine. I like hot chocolate.
I like that.
Girl after my own heart.
Yeah.
I do the same.
Yeah, she knows what she's up to.
So how did you get involved in ECMO here at UMass?
So I think that was a little bit of a stepping stone. We don't have to go through all of it, but even back to like residency, I've been lucky enough to have other attendings here invite me to the table to work on things like clinical practice guidelines, policy. Finishing fellowship, and I had already written like our ARDS guidelines and protocols here. So they invited me to have a conversation with the people that wear suits, people much more important to me, about should we lift the moratorium on ECMO at UMass to support COVID. And so that was like one of those subcommittees with a limited amount of people. It's not that I had anything magical or that important to say during that meeting, but knowing that I was already interested in it, expressed interest, and kind of followed up on it. When the pandemic settled down, the answer was no. We did not want to start doing ECMO then. But when that settled down, and around kind of like mid-2021, we actually kind of looked at it and said maybe we should try to expand our institutional footprint and start really doing ECMO. They invited me to those meetings. And that was kind of just an informal role. It was a couple people in CT surgery, and it was a couple people in cardiology. They wanted someone in pulmonary. And so it kind of just started off as more of an informal conversation for the first few months of it before it really turned into a formal committee. We're going to do ECMO. And that's been, that's evolved a little bit over the years. But for the last really like 4 years or so, there's been a core group of us, the faces change every once in a while, that meet like once a week, every week, and talk about it.
That's so cool.
Awesome. And right now, the way I understand it, we cannulate for VV ECMO, but we really only do VA ECMO down with the CT surge people, correct?
Correct. So, I could chat about that forever, about how that is. So I guess dealer's choice, like I could talk about the background as to how we got there, or I could talk about what we currently do first.
Yeah.
Up to you guys.
Yeah, tell us what you do. What do you do?
Okay. What do we do, or how do we get to what we do? Or yes.
What are we doing right now?
What are we doing right now?
State of ECMO at
Current ECMO. So we get about 45 to 50 activations a year. We accept variably, but overall we usually accept about 50%, a little bit less of activations. And that's actually our goal. We've actually kind of met that. We want way more activations. We want people to be calling. If they don't know if they're a candidate or not, we'll call us. We'll talk about it. So we get about 45 to 50 activations. We usually accept about 50% of those. The lion's share is VA ECMO. And for VA ECMO, we cannulate them, or we'll accept them, initiate them, cannulate them, keep them throughout their hospital course. The only exclusion to that is 1, if they're already followed in another hospital. 2, if we think they need a heart transplant. Or 3, if they need a BiVAD, like a biventricular assist device, as a bridge to decision about a transplant. Those are the BiVADs, and heart transplant are 2 of the things we do not do here. So if the bridge or the escape from ECMO includes those things, then we transfer them out as early as possible so they can be evaluated by other institutions.
Would you cannulate them here prior to?
Oh, for sure. Yeah. Yeah, with that usually, and it's not always, I don't want to say always, but most of the time, and I'm a pulmonologist, so the cardiologists listening in can judge me all they want. But usually you want things to settle out, see what level of recovery they can get. Can they come off an ECMO circuit onto an Impella? Can they come off just one ventricle support devices? Can they come off altogether? Kind of get that pace of play. And And then in the meantime, in the background, you're looking at their comorbidities, their age, their wishes, their wants in life, talking with families, would they buy into this very difficult road about eventually getting to that destination of transplant or biventricular assist device? Would they accept that? So usually we don't know right away. And so the longer you wait to decide about putting someone on ECMO, VA or VV, you are exposing them to decreased end organ perfusion, oxygenation, depending on what the underlying issue is. So a lot of times if they're a candidate and if there's a candidate and they're an indication, unless there's something a clear barrier, we'll just put them on. Because the longer you wait, the worse outcomes you're going to get. That's especially true for like PEs lately.
Interesting. So because you said there's hard indications, and then I feel like I've heard of some kind of softer indications that maybe you'll call the ECMO team because you're like, I'm not sure if they'll take them, and maybe some centers would and some centers wouldn't.
Yeah.
So what are the hard contraindications that we should know, and then what are some of the softer ones?
Yeah, and I think at least like as the program's expanded, I think some of the things that we said were like absolute hard indications, that is a no, have really softened. So one example of that is when we started doing ECPR, we wanted to do it very cautiously because if we accept one, we're a small volume program. So if we can only really cannulate and keep 2 people on the circuit at once, if we accept an ECPR saying, let's give this person a chance, and then a STEMI comes in the next minute, we are now full. Mm. And the ECPR usually don't have the convenience of really hashing everything out, knowing everything about a patient. Mm. But we had set this strict guideline of, for ECPR cases, our age cutoff is going to be 55 and it's going to be firm. Within the first 6 months of offering it, we did 2 right in a row, patients in their 70s who had no comorbidities and were super healthy. Mm. So we were actually going off-label anyway for us, so we changed our policy to reflect that. Mm. Similar with the BMI of 40, that was 40, and then we kind of wiggled it up to 45. And then it comes down to like surgeon comfortability. So we have some new surgeons and some new set of eyes here who are much more comfortable at higher BMIs. So we've cannulated 2 patients at or above 50 recently. And so that ties into what I was talking about, where if you don't know, call us. Because a lot of the calls that we've had, even if you're looking at the checklist, say, oh, this is an absolute contraindication, we've changed that, or we've accepted them anyway, and then it's changed our policy. So the obvious things, limited life expectancy for other disease, advanced cancers that are either refractory to treatment or we think that the time is limited. Obvious contraindications to anticoagulation, so you have to be on therapeutic anticoagulation for VA ECMO 100% of the time. Never say 100, sorry, but most of the time, the vast majority of it. Recent traumas, overt signs of bleeding recently, so we know that risk is going to be elevated. Wishes, so they need to be able to be consented for a blood transfusion. So Jehovah's Witnesses, unless they accept that, would not be a candidate. And then difficulty with vascular access is, again, that's kind of a conversation. The one thing that I would say people think is a contraindication and ethically is not is like social determinants of health and social history. So we had somebody that was found downtown unresponsive in cardiac arrest a couple of years ago in the middle of winter, and they were hypothermic, and there was an activation. And someone on the call, well-meaning, said, well, clearly this is some form of overdose. But it's important to keep in mind, well, what if that's not the case? Like, what if that's like a WPI student who was going to get takeout and collapsed on the street? What if he has no social issues? You have no medical history. So there are social determinants of aspects. Somebody is going to be put on an ECMO circuit, but they've left AMA 100 times. They've refused aspects of their medical care. Not just accepting of an ECMO circuit, but what if they wake up with a stent in their heart and they need dual antiplatelet therapy and they never would have accepted that? Well, then those are very valid reasons to not put someone on a circuit, because you're bridging them to nothing. You're supporting their acuity, but they're not going to do the thing they need. So now you're just extending this probably end of their life. We've kind of loosened on the contraindications. I think that's a good, like, off the top of our head list. We could talk about VV. The VV contraindications are a little different.
Yeah, can we talk about that?
So the indications are, severe hypoxia, severe hypercapnia. Those are pretty straightforward. but it's similar to the heart, where like you have to have a destination. For VV, they're not as often hemodynamically unstable. They're not as often having a lot of end organ perfusion issues. And so if you get them on a circuit and they're tolerating it, they can stay on that circuit for a very long time. So it really comes down to, this is a support device. It doesn't treat anything. Is the issue they came in with treatable? Because you can leave them on a circuit for a long time. And that can be really ethically, morally, emotionally difficult.
It's confusing.
So if they come in and they have ARDS and it's from pneumonia and they're young with limited comorbidities, yeah, put them on a circuit, because that person will probably recover. Will they recover back to true baseline? Probably not, but they probably can recover off of a ventilator at some point. Whereas if they have ILD, interstitial lung disease, sorry, just spitting off the podcast this year.
Just in case people didn't know.
Just in case somebody stumbles onto the podcast adjacent to like some other TikTok.
When we're famous.
So when we're famous. So they, if they have ILD and they've already been on therapy and they come in with a flare and there's evolving fibrosis and they haven't been evaluated for a transplant or they're not a candidate, you can really harm them and their families and the institution by putting them on a circuit, because it's not realistic they're going to have a bridge. So for VV, it's bridge to recovery is the most common. Bridge to decision does happen. And by that, I mean, you have something that's evolving, but we don't yet know if you're a transplant candidate, but we need to evaluate you. So we're going to give you that time on the circuit so we can wake you up. A lot of the VA cases can be extubated and wake up, which is kind of cool. So that you, your family, us as the medical group can assess you. Is there an exit strategy, usually including transplant? And then bridge to transplant. So patients that have ILD, advanced disease, COPD as well, they may already be listed for a transplant and then they come in with a flare, exacerbation, some sort of setback. If we already know they're a transplant candidate, then putting them on a VV circuit just makes sense, because they're going to get a transplant. They're already listed.
So are they kind of bumped up on the transplant? Like, let's say they're already on the transplant list. If they're now have a downturn, are they bumped up while they're on VV ECMO? So
short answer would be yes. But they're not as easy to come by. Lung transplants are a finicky thing, and their life expectancy, the transplanted lung is lower. They're breathing in stuff all the time.
Muck.
Yeah. And so, and then you put on immunosuppressives. And so, there's a lot of stuff to get through. That would definitely, we're not a lung transplant center by any means, so I wouldn't want to speak too highly on that. But that is an important part of it. That, if they're getting sicker and they're already accepted, should they be going up similar to our livers? Yes.
So since we're not a lung transplant center, I would think that it would be very helpful for us to have VV ECMO, but if we don't have a bridge for that patient to lung transplant, does it make sense for us to be considered a VV ECMO center?
Totally. So we don't really want to be considered a VV ECMO center in regards to those bridges to transplant, bridge to decision. If we did that, if we said, okay, we're going to start accepting all VV cases, including things like ILD, advancing ILD, people can get stuck here. Because let's say we put someone on a VV circuit for an ILD flare here, and they're not recovering, and then we find out they're not a transplant candidate. Well, like I said, now that person's awake, or they could be awake. The family's awake, and now you're stuck on the circuit. When do you stop it? When do you not stop it? And you don't have a destination. At the same time you're doing that, keep in mind, because we're a small center, that occupies one of our 2 ECMO circuits that we keep. So now you're talking about somebody being on one of your 2 ECMO circuits for the entire institution
with a bridge
for weeks.
Yeah.
Right, with the bridge
so we do not want to be, or our goal currently is absolutely not to be that kind of center, because I think we would harm that patient, and we could potentially harm another patient when they come in and we can't offer what we can. But that doesn't mean we shouldn't be able to keep some. So the current model, and this is again, this may change. The current conversation we're having, we're actually having a meeting about it later this week, is keeping very select aspects of VV ECMO. Our current model is if they need VV ECMO, they have an indication, they don't have a contraindication, and they need it now, we will cannulate them at this institution, and we will stabilize them until we can find them an accepting institution. We no longer need an accepting institution up front. The next phase of it that we think is reasonable, we being myself and the other medical director, is to keep things like obstructive lung disease. So your status asthmaticus comes in, the circuit should correct the majority or a good portion of their oxygenation ventilation issues. It'll allow their lungs to settle down. And then they should be off a circuit in the next few days unless there's complications. And that can happen. But transporting that person on VV ECMO is not trivial. It's not trivial to transport these patients at all. So the idea would be that if we know someone has a bridge to recovery and that bridge is short in timeline, then we should start keeping those patients. Yeah. That's the only way we're going to get good at it. It's the only way we're going to start being proficient at VV ECMO. Like I said, transporting those patients does not necessarily make sense if you can support them here. Because it's a short interval, we won't be putting our VA population at risk. So there's a lot of benefits to it. The ever important things like flow in and out of Three Lakeside and staffing is a concern. In tune with that. So VA ECMO mostly obviously is cardiac for the most part. CT surgeons, cardiology, they're good with that. That's their whole thing. You start putting status asthmaticus on a ventilator and they're admitted under CT surgery, we're getting pretty far away from their expertise. So we need to get pulmonary critical care more and more involved, more comfortable managing those patients, and figure out a way for them to eventually be the primary team for these VV ECMO cases. I think that's something that's going to have to happen.
Very exciting. I feel like that's coming up soon. Like I've just, even working in the EICU, our telemedicine here at UMass, we had recently a patient who had like a hypoxic cardiac arrest from status asthmaticus. So I'm sure you got the call. Yeah. But, I was like, I don't even know if we do VV ECMO here. But so exciting because Dr. Mullen from our first episode, she was that patient's advocate. And I think this is like a really good sort of evolution. She was excited about it.
And we've had two of them. I'm not sure which one that is, but the one of the two that we transferred out, and again, we would like to advocate that we would keep them, but they went to MGH. They had them extubated like the next day. They stayed on the ECMO circuit, but they were extubated within like 24 hours, wide awake, following commands, participating in these interactions, and then they weaned down the circuit and decannulated it, I think at like 72 hours. Don't direct quote on that, but that's a very exciting patient population to keep. Again, we don't want to do anything that exposes other patients to staffing limitations or risk. We don't want to do anything we don't think we're proficient at, but I do think we're close enough as an institution.
So let's hone in on VA ECMO. So walk us through, you get the consult, you're going to cannulate. Tell us about where you cannulate the patient, how you manage the patient day to day, all of that fun stuff.
And just out of fairness, when you say you're going to cannulate, it's the ECMO group. Pulmonary is strictly part of those decision-making and rounding. I am not just stabbing and grabbing cardiology patients. It comes down to the patient level. So the best thing we could do is do it in the cath lab. You have fluoroscopy. They're used to doing these type of procedures with a lot of complicated vascular access. Anesthesia, cardiology anesthesia can be there, or anesthesia critical care. Everyone knows where it is. It's safe. It's sterile. That's the ideal location. So if a patient can get to the cath lab, we would like to do it in the cath lab. If they are unstable, we will cannulate elsewhere. So we will cannulate in the emergency department, either here or Memorial. And then bedside through Lakeside. Those would be the most common places. Depending on how that goes, because it hasn't, there's been a couple times where we said, hey, we can get to the cath lab. And patients have actually coded in the elevators, and then there's a little more urgency to it. But generally speaking, we get our activations wherever it is. If they're stable enough, we'll transport them across campus or within this campus to the catheterization lab. And then it's CT surgery and interventional cardiology cannulate together.
Okay. And access sites, where do they access?
Typically femoral and IJ. So sometimes, well, not always, but you could do bifemoral depending on your vascular access, so they could have arterial and venous on the same side. Depending on if it's VV, then you might be using something like an IJ. A lot of these patients have pretty significant comorbidities, and a lot of times it's just wherever you can get in. Mm-hmm. So, and then the other one being vascular issues, and as well as habitus. So, vascular surgery has been phenomenal with help. Always been able to help us cut downs, making grafts, things like that. The one thing that I learned this because, again, we're a pretty new institution and I'm a simple pulmonologist, is when you're putting those cannulas in on the arterial side, they are large enough to cause distal limb ischemia. We've had one case of that despite having a perfusion, but usually you do a distal perfusion catheter, which is from the same site, and it goes distal, antegrade from the catheter.
So definitely something to monitor.
That's like the venous, or no, that would be the arterial side, right? That you need to reperfuse.
Yes. So as you put in the arterial catheters, it's a little backwards. Like if you do the femoral catheter for ECMO, it actually is going retrograde back to the heart. So it pushes towards the heart. And so you're, obviously, if you're pushing this way and you have this large catheter, so you're going to get no perfusion this way. So you have a distal perfusion catheter that comes off of that one and will perfuse that limb. Then they all get a radial, ideally right radial arterial line. And the rationale for that is as blood vessels come off of the aorta, that is the first place that you'll see native perfusion from their heart. So if they come in and they're in asystole, the ECMO circuit is doing everything, which means generally the oxygenation, no matter where in the body, should be relatively similar. As they get native cardiac function, they start having more pulsatility. They might start perfusing parts of their body, and you need to know that immediately because they might be oxygenating adequate on the circuit, but then their native heart kicks in and that blood may not have good oxygenation to it. So you may have a PaO2 of 100 and something in this arm, and then this can go from 160, and then when they start getting their own pulsatility, it can go right down to 40, 60. And you need to start supporting that part of the body with the ventilator. Does that make sense?
Yes, yeah.
So it's kind of not cool. I don't think that's the right word. But it makes physiological sense. And it's been really helpful because we've seen it in live time with the ECMO specialists. Where like an hour to hour, they'll be like, oh, PaO2 was 250. And so the closer you can detect that, there's some cutaneous monitors now that we use as well. They're not perfect, but they're pretty cool.
Very cool. So when you cannulate, what are the settings that you are utilizing and then managing on a day-to-day?
So realistically, I wouldn't say it's set it and forget it, but getting them on the circuit and reconstituting perfusion is the most important part. There's a couple different settings. So you do the pump speed, your liter flow, and then we call it a sweep gas, which is how much CO2 you're pulling off and how much FiO2 you're reinstilling. But for the most part, depending on what you're doing, like day to day, those numbers, like for the liter flow, can be anywhere between like 3 and 5, and you're kind of just matching your RPMs to support that. And then based on serial ABGs, the ECMO specialist or the perfusionist, depending on what kind of institution you're at, they're titrating the FiO2 and the sweep gas. So it's not, I don't want to say it's different than a ventilator, but a lot of the times the circuit is the circuit. It's almost like I'd say it's closer to almost like a dialysis setting where like, here's what we're dealing with clinically. Here's the expert perfusion specialist making those adjustments to support it. And then they notify you if they're having issues and troubleshooting it. The only couple like low that can propagate thrombus, and that can be anywhere, either in the circuit or in the patient themselves. You never want to obviously have hypoxia, but you don't want to have hyperoxia either. So making sure you're not oversaturating. And then the sweep gas, which is pulling off CO2, at least initially, you don't want to blow off CO2 too fast. It's very tempting, especially with ECPR, to say the PCO2 is 120. They're severe clinically acidotic. Let's blow all that off. But if you correct it too fast, and you can with an ECMO circuit, you can cause alkalemia, and that is bad for cerebral edema. So even though it's a little, you don't like waiting, it's not comfortable, you actually want to go slow with that.
So I kind of want to take a step back for those of us who don't know, just to define kind of VA versus VV ECMO. So VA is, bypass the heart and the lungs. So you're supporting the heart and the lungs. And then VV ECMO is really just, you want to support the lungs because the lungs aren't working, but their heart is working and is pumping. So in terms of, so I assume they're intubated at this point in time for, let's say, VA ECMO. What's happening on the ventilator? What adjustments, if any, do we make on the ventilator?
So that is, there's some variability to it, but for the most part, and we talk about this with like ARDS too, but the ventilator's great. Like we invented ventilators, we can oxygenate, we can ventilate, yahoo. But we've found time and time again that the ventilator is not a trivial thing. It causes a lot of damage. It's not physiologically normal to have air pushed into your lungs. We use negative pressure native when we're not on a closed circuit. So the real name of the game is doing as much damage or as little damage as possible on the ventilator. Not necessarily am I adequately ventilating and oxygenating. You're almost better served using the circuit, at least up front, the ECMO circuit, to start. So if somebody goes on VA, you can do a lot of correction of oxygenation and ventilation through the circuit, and you actually want to drop your pressures as much as you can, specifically the tidal volume. And then you increase your mean airway pressures to avoid things like atelectasis, atelectotrauma with the PEEP. So it's very common, you'll see, and this is not anything but like with this ultra low tidal volume ventilation, regardless of VA-VV, where you might see somebody with a low respiratory rate of 10, a PEEP of 10, your FiO2 is weaned down, and then your tidal volume is ideally at 6 mLs per kilogram or less. And not everybody can get away with that. Certainly with VV, it can only replace so much of what you're doing, but that's the goal. So the ventilator, again, you want to prevent harm. You want to do as little as possible. And then the only time that changes is now you're trying to wean them off the circuit. You need to identify, can the ventilator do enough? Can this patient survive off of the circuit? So as you start to wean down your ECMO circuit, you also need to start titrating up your ventilator.
So it's kind of a wean onto the ventilator. But I assume, depending on how long they've been on VA ECMO and then also not using their musculature, that can be very difficult then to extubate them. Mm-hmm. So does that affect the timeline of when they're extubatable? Totally.
Yeah, 100%. And it's hard, with VA ECMO, they're on sedation. You're not necessarily doing all your SBTs like you normally would. If they have an ongoing cardiovascular process, even that small amount of PEEP is keeping their lungs kind of dry and pushing it out. How do you know they're ready? Are they going to flash right away? Are they going to have a cardiac ischemia and they're going to... To know, we have a lot of criteria here, FiO2 criteria, PEEP criteria, stabilization, what is their cardiac index, what is their cardiac output, but nothing's perfect. But what they do, they mostly at the bedside is you'll do like intentional turn downs under observation. So you'll get the multidisciplinary team there. You'll try to make some event adjustments to kind of guesstimate what sort of support you think the patient needs. And then you'll turn down the ECMO circuit, and then you monitor cardiac output, cardiac indices. All these patients have radar casts and swans, and then a lot of times, and I don't know if this is just UMass specific, but a lot of times we have an echocardiogram in live time while we're doing the turn down. So keep in mind that VA circuit pushes against the heart, and it can actually reduce pulsatility of the heart and ejection fraction because pushing against it, it's afterload. So as you reduce down that, a lot of times you actually see some recovery of that function. And so you can kind of make a good estimate. Is the blood pressure being maintained as we turn the circuit down? Are they oxygenating? Are they ventilating? What is the heart doing? And so you get a realistic idea of how they're doing.
So it seems like we have kind of all of the tools to see how they're doing real time. It's just a timing issue of when do they meet all the criteria? When are they kind of bouncing back, and when we can realistically kind of extubate them.
Totally.
Cool. And this would be you like decreasing the flow on the ECMO.
The ECMO specialist or perfusionist, but yes. Yes, 100%.
So I think we're like throwing around all of these. There's an ECMO specialist, there's an RT, there's a lot of people involved in the team. Can you just go over who exactly is on the team and who needs to be kind of specialized and all of those sorts of things?
Yes. So here. Yeah. So there's the ECMO by location, by staff, and personnel. So ECMO isn't just something where one physician says, I'm doing the ECMO on this patient. It really does take an entire multidisciplinary group. So here on like a provider level, every activation has CT surgery attending, CT surgery APP, who is kind of like their lead. So we just hired this new guy, Will, who's awesome to do that. So there's 2 people from CT surgery. There's a cardiologist, interventional. There's a heart failure specialist, and oftentimes those can be the same person. There's anesthesia critical care, who even though they're listed as the attending of record as CT surgery here, Actually, anesthesia critical care is who rounds on them primarily and during the day and manages them. You then have the ECMO specialist. ECMO specialist is a respiratory therapist who's been specially trained to manage ECMO circuits. Other institutions use perfusionists as well, which they're definitely not interchangeable per se. They're very different skill sets, but just two different approaches to the same outcome. And then the nursing staff, pharmacy are also closely involved. Pulmonary is involved in every single case as far as, like, again, providers. The decision to cannulate, I agree we should put this person on a circuit. If it's VA, is cardiology, anesthesia, CT surgery. If it's VV, it's CT surgery, anesthesia, and pulmonary. So that decision there's a very distinct difference between those two, and it has to have quorum. But bedside, it really comes down to ECMO specialists and nursing. They're the ones that, we come by and we round for 15, 20 minutes in a day, and anesthesia critical care is, back and forth reassessing the patients, but they're the ones sitting there the whole time. And so you can imagine if you tried to put these patients on an ECMO circuit into different units, 12-hour state, if they're not trained in it, if they're not really proficient, there's going to be either complications or they're going to miss the complications. The early identification of problems or clinical changes, that's where it can be missed. So that gets down to the location, where here we're currently only doing this in 3 Lakeside. Now, if they need cannulation or initiation somewhere else in the hospital, fine. But our usual goal is to get them into our ICU or out to an accepting hospital within 4 hours. We're very far away from that training. I think that's part of our conversations that we have with the APP group is people, they know we have this program, but we're not even at the point where people know the indications, contraindications, much less know how to manage it. We're very far away from that. And we've had really good outcomes, but we've had them only in 3 Lakeside, and that's been very intentional. So the actual physical location of 3 Lakeside has been a big part of this. The individuals that are rotating in and out of those rotations is less important.
Do you imagine, maybe not soon, maybe within the next 10 to 20 years, that we could have a ECMO patient, or a VV ECMO specifically patient on, let's say, 6 or 7 ICU, which is our medical ICUs, and kind of you would be the pulmonologist taking care of them, and then we'd have a specific RT or perfusionist who's in that room? Is that within what we can do?
Yep. So that would, and I think 20 years is a little much. I think we can go less than 20.
Great.
I think we can do it.
10? 5?
I would say less than 10.
Great.
So the kind of our theoretical, specific to VV, theoretical thing is we want to go from, we initially said we're not doing any VV, period. And then we said if you have an accepting institution, we will cannulate them and do it here. And then we said we will cannulate and initiate them with VV, but you have to find us an accepting institution. And then in the next phase, like we talked about, we're going to start keeping them. And that will stay in 3 Lakeside with CT surgery, the same multidisciplinary rounding group. Our hope is if we start keeping VV and we increase that volume, the next phase of that would be they're in 3 Lakeside, but now we're going to have pulmonary start to manage them primarily so that the providers within pulmonary critical care get more proficient and more comfortable with that. And kind of parallel to that, start bringing nursing staff, nursing educators out of 3 Lakeside and starting to train up and staff up the other units. And we probably would have to do it in a stepwise fashion. I don't think it would be the right thing to say we're now going to do VV in a traveling fashion, different units. We would probably identify 6 or 7, or, there's been rumors about building more ICUs here for a decade. But,
On Lakeside, yeah, right?
We want to be really intentional and make really small, safe steps at a time. So the next step would probably be cohorting a certain group in either 6 or 7. You are going to be trained up in ECMO circuits so that we can start keeping VV at that location. I don't know if you've heard about the anatomical issues with those units, but pretty much everyone on ECMO circuit is also on dialysis. Not everybody, but
The rooms are small.
a ton of them. Itty bitty rooms. So we've got an itty bitty room problem. And actually over at Memorial, the rooms are much bigger, but that is not reasonable to have 2 institutions. We're not going to do that. So we need some form of anatomical renovation of 6 or 7, or the technology is evolving. These circuits are getting smaller and smaller. So figuring out a way to get a ventilator, you need to know that you can do a ventilator, an ECMO circuit, and a dialysis machine in these rooms, basically. Does that make sense? And I mean, then you're talking about EEGs. You can really see those rooms get filled up fast. And then transporting them. So the elevator from 6 and 7 down to the second floor for imaging, especially if it's stat, that's actually very difficult. During the pandemic, when CT surgery was briefly in 6 ICU.
Right. Sounds like all of these logistics have been extensively discussed.
Yes.
I feel like based on your description, 2 Lakeside, I mean, it's right by the OR.
Which
it's
is
only
the
on the
neuro
second
ICU,
floor.
by the way.
Right. It's a neuro ICU, but that feels like the perfect location and kind of a missed opportunity because the OR is right there. So if anything happens, you can just cannulate them and put them in a room right there.
Yeah. I mean, your brain people are going to be upset that you said this.
I'm part of the brain people, so I guess I am upset.
Yeah, this is mostly like an institutional podcast. We can kind of brainstorm. So 2 Lakeside absolutely would be a great location for ECMO, but then you would sacrifice a lot of the brain stuff. And those aren't totally cross-compatible trainings, right? So you'd have to have 2 pretty distinct training staffs. The one that I talked about that I think, selfishly, I actually think it's a really good idea, but is the 3 step down. So step down has been getting more and more complicated, but that nursing staff already works with CT surgery, vascular, and cardiology, and it actually is physically a continuation of 3 Lakeside. They have conference rooms on both sides of that wall that can actually be retrofitted into an ICU room. And so what you could do is take the first 2-3 beds of step down and make them either crash backup beds for ECMO or make them ICU rooms, actually change that narrative. And if you increase that census up higher, then you could probably accommodate more and more of these. So that would be, for me, that's what I would try to focus on, is how can we cohort some of those current step down patients into another part of the hospital while expanding into 3 step down. Because then again, it's all on one floor. You're just right across.
And those rooms are huge over there.
Those rooms are
They're huge.
And it's not like you would put, right now we try to keep our ECMO patients on beds like 1, 2, 3, 4 in 3 Lakeside, because that's right where the CT surgery APPs sit. We would just go like 5, 6, 7, 8, and then make medical cardiology
further down.
in the step down.
Gotcha.
Soon all of UMass will be cannulated.
I know, right?
On ECMO, every single patient.
That's it. We'll be cannulated.
Yeah.
Don't do that to me, please. So what is like the immediate next step, or what are the current things that like you're working on either with the ECMO committee, or like what's next steps?
So some of that is constant. So we're always, like I mentioned, based on all the activations and the cases we've had, we change our policy and guidelines. So we are just finishing updating a couple things like our hypothermia guideline, because a couple things changed with TTM. We are looking at expansion to VV. Can we do it? And if we can't, we're not going to. Like, we have to do it in an excellent fashion. So we're actively looking at that. We've had a couple calls recently that we hadn't expected, like immediately post-transplant ECMO activation. So that's I don't know how, but it's been 4 years. We haven't had a single activation of a transplant patient. And so that wasn't even on our radar. So starting to create dialogues with them. You can imagine they are very unhappy about transferring their patients out of this institution, as they should be. And getting another institution to accept an immediate post-transplant patient is not trivial.
Where they didn't do the transplant themselves.
Right.
Yeah.
Right. So we're looking at those type of things. We have a couple rolling M&Ms coming in, not on like an individual like sentinel event. We just review every case basically. So that's kind of where we are. There's some things that sometimes the most important thing is to not do anything. Data out there from other institutions like ECPR, perfect world, we would be out there in the wild cannulating people in the field, because again, the faster you cannulate somebody, the faster you reconstitute perfusion, the better the outcome. But it's just not possible. We just don't have the support to do that. We don't have the staffing. And if you try to overstretch yourself, if you try to expand too fast, you're not going to do it as well as you're supposed to, and then you're going to have bad outcomes, and then you're never going to do it. So a lot of the conversations we have are, what's the barrier to each of these expansion opportunities? Which one of them is the most feasible? go and talk to the people that are pushing for the other ones and explain why we're not going to do it. And then let's focus on a thoughtful step at a time.
I like it.
Sounds like a lot of work, but
Yeah.
something that's worth doing.
Yeah, but it's exciting. It's exciting work. It's not I'd much rather do that than like my annual evaluations or something.
I'm with you on that one.
Well, awesome.
Yeah. I feel like we have so much more to do. I have one last question, then we have kind of our ending. Do you feel like we need to bring in more people from like outside of UMass in order to kind of bring all of this to fruition, or can we just train within our own staff?
I think we can train with our own staff. It's very helpful. We've had a couple hires like within our group where they come from institutions, they did ECMO all the time. So that's great. They still have to learn how to do ECMO here. So just keep in mind, those outside people, they come in, they have more reps or they have more experience, but they now don't understand the complicated nature of our institution.
Yeah.
So that's also a problem.
Such as the elevators and the walls and all that.
Right.
All that stuff. I get that.
Yeah, we have a couple of people in our group that were like, why can't we do this? And it's like, they're asking, like, I've never even imagined why you couldn't do that. But here we are. Yeah. The other medical director, Yusuf, Dr. Raban, he came from Tufts, and they used to not do VV just like us. And he said the only thing, the thing they had to do was just start doing it. And because after just a few cases, you could read all the books in the world, you can watch all the podcasts, but doing it was like by far and away the most effective thing. He said within like a couple cases, everyone got exposure to it. You get comfortable, you learn what works and doesn't work. We have very smart, hardworking people here. I'm very confident we could do it with the current people we have here.
Awesome. That's great to hear.
Like, let us know if you want
right?
some PAs to help out.
We poached Russell from the critical
I
care
heard.
EP
He's very
group.
good.
So he's in cards now. He's down in short stay, just waiting for ECMO to come in. I think that at some point that's going to go from like we cross cover or we're dedicated on this service to everybody has exposure and everybody's trained to some extent on it. I think that will happen. We're excited about that.
I love that. I'm getting excited just hearing about it.
Me too.
I'd love to see that future.
Well, thank you so much. Really quick, though, we ask all of our guests, what is your anthem song? Just your
Like your
day-to-day. You wake up in the
interpretation.
morning.
Yeah, open to interpretation.
Okay.
Like, define your life.
So with the kids right now, and I'm probably like anybody listening, K-pop Demon Hunters is right up there.
I love that.
Yeah.
I love that.
An entire weekend skiing with my oldest daughter, listening to the same like 4 songs on repeat. Never once did she get sick of it. So now that's me. Now I'm listening to that. Shout out Takedown. And then I don't know why. I think it's like it might be like some sort of like mental health illness, but there's a song In the Summertime by Mungo Jerry. And it was in like the movie Wedding Crashers from like 20 years ago. But like to this day, at least once a day, it gets like caught in my head. So I guess that's like my anthem. But it's like, it's one of those like painful anthems because like it's not that exciting. It doesn't amp me up. It's just there.
Is that
It's
like your
comfort
burnout song?
blanket.
Is that like when you're burnt out or like, you have a bad day and that's the song you listen to?
I don't even put it on. It's just in my head.
It's just
Kind of like an
it's in his
aura
head.
prior to a
Yeah.
seizure. You know?
Yeah, it's just sustained. It won't stop. Yeah. If I have a true like I want to get pumped up, my middle child, the 4-year-old, really likes Enter Sandman by Metallica.
I love that song.
Yeah. So that's like a real anthem. That's probably the right answer. You should probably delete the last 2 minutes and just put that in there.
Yeah, we can do that.
I'll edit it out.
Yeah.
Yeah.
Like it's not K-pop Demon Hunters.
Awesome. I love it. Well, thank you so much for joining us.
Yeah.
That was great.
Appreciate it.
Yeah.
Amazing.
Invite me anytime. We'll chat.
Hey, maybe we can do this maybe in the next like 3 to 5 years when ECMO is actually a thing here.
Sure.
Yeah, let's redo it.
10 years. 20
10.
years.
No, not that long, Katie. He said like less than 10 years.
20 years was heartbreaking.
All right, I'm sorry.
Will he still be here?
Yeah, right. He'll still be here. He'll be here, right?
Yeah.
He hesitates.
No, I'm just trying to think like when am I going to burn out? Like that's important to think about. I think I'll still be here.
I don't think I've
I'll be
ever
doing
seen you
clinical
burn
medicine.
out.
No, I like it, but like
You
at
like
some
it too
point-
much.
Yeah, at some point you got to do like something else.
Yeah.
Victoria wants me to open a med spa.
Ooh.
Ooh.
Can we put an ICU in it?
You're like in the thick of it right now. You're very passionate.
Yes, I want to do that.
Yeah.
So maybe I won't like burn out. I'll just be forced out. Like if my spouse can like figure out a way to force me.
And then we'll all be invited to the Mickelson med spa, right?
Yeah.
Oh, I love that.
Yeah.
There's like a mechanical ventilator supposed to help make your lungs pretty.
Extra
You
oxygen.
wake up pretty. Critical deconditioning.
They sedate you. They're like, just go to sleep.
Cool.
I love it. Awesome. That's a wrap.
Cool.
Thank you for joining us on another episode of the Crit Chat podcast.
It's critical chats, Shayla.
Remember, you can watch the podcast video on YouTube or listen to us on Spotify, Apple Music, CastBox, or Amazon Music.
Everywhere.